Good evening, everyone. Welcome to Dinner with the Doctor. It's been a while, hasn't it? For those of you who have come regularly. We missed April, obviously because of the virus, but we are glad to be back in action. So I would just like to go over a couple of things with you before we get started. I see that most of you have tried to keep yourself separated by a pew, which is good. I don't like the social distancing part, but I know it's necessary. But thank you for doing that for us here tonight. Normally, we would be in the fellowship hall, which is behind us, and we would be eating right now. But in lieu of that, we have prepared a lunch for you to take home tomorrow, so you don't have to prepare your lunch. We will hand that out at the end of the program. Same place where you registered, we will have the food there for you to take. And it's all ready to go, you'll just have to put it in a sack. And we will provide that for you as well. Speaking of food, I'd like to just review the recipes with you. We have made you a quinoa salad, a Thai quinoa salad, and a New York Times black bean veggie burger. So let me just say a little bit about the quinoa salad. If you have not cooked with quinoa before, it's crucial that you get a very fine strainer and rinse that quinoa very, very well. Otherwise, it will have an odd taste to it, a kind of a bitter taste. So rinse and rinse and rinse until the water comes out clear, okay? So that's the first thing about the salad. The other thing I wanted to bring your attention to is regarding the broccoli. You can do the broccoli any way you like, but apparently the finer you chop the broccoli, the better it is for you because it releases, now let me make sure I get this right. It releases a chemical called sulforaphane. And the smaller you chop it, the more it is released and the better it is. And of course that's a cancer-fighting chemical or element. So like I said, you can do the broccoli any way you want, but if you want to get the most benefit out of your broccoli in this salad, chop it fine. Let's go to the burger recipe. On there it doesn't talk about heating the mixture that you will whiz up in your blender. So you're going to put everything in your blender and whiz it up. Before you add the oats, I would recommend that you just warm that mixture up so that the oats will absorb it easier and better and quicker. Otherwise, that's the only difference I did when I made this recipe. Any questions about it? I know that you're not eating it and all that kind of stuff. But if you have a question, just let me know. You can ask me now or later. Correct. Blend everything and then warm it. And like I said, you don't have to, but I really think the liquid is absorbed better. I did put a jalapeno in it, but I did remove the seeds so it wouldn't be real hot, but you don't have to. Any other questions on that? Okay, just people that are coming in, if you could sit so that you are a row, there's a row between you, that would be best. Oh, Brenda, you had a question? Yeah. And you can do it any way you want. You could use all quick oats if you want to. I just find it too much like oatmeal when I just do quick oats. Any other questions? Okay, we'll go on. Our next dinner with the doctor, you received that card when you came in, is by Dr. Raymond Cohen. And he's a radiologist, and he will be talking about women's imaging. I know that there are some men here, but I'm sure you men know of or have women in your life that have required women's imaging. So it's for you as well. So that will be September 8th. And dinner with the doctor usually happens every quarter. It's not quite that precise, but think about it that way. Once a quarter, we have dinner with the doctor. And hopefully next time when Dr. Cohn is here, we will be able to actually have a meal in the fellowship hall. I'm delighted to have Dr. Overholt with us tonight. She is local to our area, and she was born right here in Greenville at Tacoma Hospital. Now, Greenville Community, East or West, I don't know. I don't know my directions here very well. She went to high school in Cocke County and then went on to college to Walter State and ETSU. From there, she went to medical school at University of Tennessee in Memphis, graduated in 2006, did a residency in internal medicine at Wake Forest in Winston-Salem, North Carolina in 2000, and graduated in 2009. Presently, she practices internal medicine at Health Star Internal Medicine in Newport, and she's opening up an office in Greenville beginning Monday, correct? Okay. But prior to her move to Newport, she worked at Tacoma for 10 years. So we're just really, really thankful that she's here. She's married to Dan, and they have 5 children. So thank you, Dr. Overholt, for being willing. But before she comes, I'd just like to focus our attention a little bit on something spiritual. Our topic tonight is called the fatty liver disease, non-alcoholic fatty liver disease. And Dr. Overholt will correct me if I'm wrong, but when I looked it up, it said that it usually causes no symptoms or signs. But if it does, it includes fatigue and pain or discomfort in the upper right abdominal area. You know, this week I have been doing some wood splitting, which is a crazy thing to do when it's 80-some degrees outside. But if any of you know, the ash tree has developed a problem in this area. It's called the emerald ash borer. Came actually over here from Asia. First noticed in Michigan, but now it's in 33 states in the US. But what affects the tree is the larva. And if you were to pull back the bark, you would see a bunch of squirrely lines all the way through it. And when you would split the wood, and a bunch of tiny pinholes all through the bark from top to bottom. And this larva affects the tree in this way. It disrupts its water and nutrient source and its transfer of the nutrients throughout the tree. I believe I forgot my phone somewhere, and I was going to read you a Bible verse. And the Bible verse is this. It's from Isaiah 55, and it talks about, come ye to the water. If you're thirsty, come and drink. If you're hungry, come and eat. And that's what Jesus is wanting to give us. He's the one who supplies what we need every day, whether it's our food, but most importantly, what we need spiritually. He provides that for us. And as I thought about that tree that was, whose system of nourishment was interrupted by this borer, my prayer for you is that you won't let anything in your life interrupt that nutrient supply that you receive from Jesus every day. So I'd like to have a prayer, and then Dr. Overholt, if you would please come. Dear Father in heaven, I just want to thank you for everyone who has come here tonight. Thank you that you are our constant source of spiritual nourishment, and that you love for us to communicate with you and to read your word. And I just pray that we will never allow anything to come into our lives that would disrupt that nutrition that we get from you. I pray that you will be with Dr. Overholt tonight as she discusses this very important topic, because it truly is stealthy, just like many habits and many things in our lives that kind of take over sometimes before we even realize that we are doing it on a regular basis. And so I ask that you will help her in her presentation and help us to understand what she is trying to convey to us. Thank you for our bodies that you have made so marvelously and wondrously, and that work together so perfectly, all the parts. Thank you for hearing this prayer. In Jesus' name, amen.
Thank you all for coming. I really appreciate it. Now, when I get nervous, I speak really fast. So if you have questions, just stop me, and then I'll calm down, and I'll answer your question, and we'll just keep going. And so I find that the best way to learn is to ask questions, and it kind of gets us in the mood. So I know we had to be really spread out, and we had to, socially distance, but I'll listen really closely to your questions. So feel free to interrupt me at any time. And so, of course, I had to start with there we go, my shameless plug that we will be opening office here on Monday. So HealthStar is a group of physicians based out of Morristown, all the way from Knoxville and Newport. We have 3 different offices, and so we're delighted to be back in Greenville. We are going to rotate providers, so we have Lori Grabner, who has a doctorate in nurse practitioner. She worked with me for many years. She loves people. She loves Jesus, and she is just a compassionate person. If you've ever seen her, you know that. Sonia Hantz was actually my nurse for many years. She started as a tech in the hospital reading EKGs, and then God moved on her heart to become an LPN. She loved it. She became an RN. She loved it, and now she's a nurse practitioner. And then Hannah Kirk, she's worked with me for many years. She was actually my PA as a student and my PA in Greenville. And I whispered to her one day, I think I have to leave my job and switch. And she said, well, I'm coming too. I said, well, you better not tell anybody until we do it. And so she's come with me the whole time, but I'm delighted that she's coming back with me as well. And so again, that starts Monday. We're going to be on Coolidge Street, just right down the road. And I'll do some Facebook stuff to show you the building soon. So let's get to the liver. Okay, now I am a complete and total nerd, and I love anatomy, so if you don't, just forgive me. But the liver has so many functions. They think it's over 500 functions that it does. It breaks down nutrients. It breaks down the medications that you take. It detoxifies chemicals. It helps with your digestion. The liver is so unique that you can actually chop it in half and it will regenerate. And there's no other organ. And I always think about those little worms, you can chop them in half and they grow back. Not that I do that, but the liver can do that. And it's amazing because if you're looking at someone who has colon cancer and it's metastasized to the liver, you can actually still have 100% function just by taking out the liver. It will regenerate and can continue to work. It works with cholesterol. It causes what we call gluconeogenesis, and so your brain has to survive on glucose. Well, the liver is what will turn your food into glucose. And so it's important, like if you're doing a low-carb diet, many people are angry because they say, in the morning I'm waking up, my blood sugar is too high. What is happening? Well, your liver made glucose. It took your fat and it took your protein and it converted it to glucose. So your liver's really smart, and it works to protect us. And so it's a very important organ. And so this is where the liver sits. It's a very large organ on the right upper quadrant of your body, crosses over the midline. It's large, it's bulky. And the first time I came in contact with the liver, besides, cooking and those things, was when I was in gross anatomy. And so in medical school, we have the honor of learning anatomy based on someone who has donated their body to science. And my cadaver, she was an 89-year-old, very thin woman. And so whenever we were dissecting their liver, learning about it, learning about the blood supply, it felt like a liver that you've probably seen in the grocery store, felt, and it's firm. But, there were 40-some bodies in the room, and we were all divided up, and I noticed that other people's livers didn't look the same. And so, in the early years in medical school, you're saying, well, why? Why is that? Why does my 89-year-old's liver look like it's supposed to in the textbooks, like you see in this picture? And why is the other person's not? And so we started to learn, why is this? And so as my other classmates were, dissecting the body and opening up the cavity, and you would notice that they were having to cut through a lot of layers of fat. And Oda Mae was very thin. We named her Oda Mae just so we would have a personal touch. And the other cadavers that were obese, we would go through the fatty layers, which we expected, but whenever we opened up, we couldn't see the organs. And so what we think about, and at least the way I thought before medical school, I thought, well, when you gain weight, it's all external, but it's not. And so the fat lobules were actually hanging on the liver. Okay, so what we did is we took off the layers, but then the liver is still not normal because some of those fatty lobules actually grow into the liver. And so that was my first thought of, why is this different? Why are we different? My patient was older than many of those patients, but yet her liver looked better. And so who gets liver fat? And so that's a very important question because it's a lot of different reasons. And so one is a condition called metabolic syndrome, and that one's very important, and we're going to spend an entire slide on that here in just a minute. And there seems to be a male predominance. We don't exactly understand why, and it seems to be more people who are apple-shaped, where you gain your weight in the central portion of your body, than the pear-shaped people who gain it in the lower portions of their body. And diabetics tend to have this more, and that is not confusing to me because I think about why do people get diabetes, and for type 2s, whenever you have increased adipose tissue or increased fat, your pancreas works overload and it gives you more and more insulin, and it has to drive the glucose through the fatty cells. Well, that's more work, and so more fat increases diabetes, more fat may increase fatty liver disease, so that made sense to me. But then babies who are born with low birth weight and babies that are born with high birth weight both have a higher predominance of non-alcoholic fatty liver disease. Is this because there's more stress to the body? Is this because the baby was in more distress? We don't know exactly. And of course, alcohol causes alcoholic liver disease. And it's interesting to me that if you go and you biopsy an alcoholic's liver and you biopsy a non-alcoholic fatty liver, they look the same. The only way you can tell the difference is by history, and you ask the patient, how much alcohol do you consume? And it has to be what we consider a moderate amount. And that's interesting because women, one alcoholic drink, and when we question patients, we're taught to double it. Whatever our patients tell us, we double it just in case they're trying to be nice. And but one drink is a glass of wine or 8 ounces of beer. And some people, I say, how much are you drinking? And they'll say, oh, I only drank one. Well, you learn that it was like, something called a stovepipe, this big old huge thing. That's not one, and I went, how many ounces? And so you really have to get down and ask, but isn't it interesting that an alcoholic's liver, something we know causes liver disease, looks the same as a patient who has fatty liver, non-alcoholic fatty liver. So I found that to be interesting. And the medication. Now, the medicines that I've listed are known reasons to cause fatty liver disease. Tamoxifen we use in patients who have had breast cancer, and it blocks their estrogen to decrease their breast cancer risk. And so they're on that for 5 to 10 years afterwards, and that is a risk. Not everyone gets it, and it's not a long-term medication, but it is a risk factor. The next one is Methotrexate, and that's a medicine we can use in chemotherapy if it's a patient that had cancer at really high doses, but most of the time that's what we're using in our rheumatoid arthritis patients, our patients with lupus, and it's actually a very common drug. But if I put you on that drug, I'll check your labs in 30 days. And then every dose change, I check your labs in 30 days to watch the liver. And if I back off the drug, the liver improves. And if I push it, it will increase. So it depends on what I'm treating and how bad the patient is and what risk we're willing to take to the liver. But methotrexate is actually a pretty commonly used medication. And then amiodarone is a medicine we use for any heart arrhythmia, but especially atrial fibrillation. And I jokingly say to some of my family members who've worked on the farm all their whole life, and they're tall and skinny and unfortunately developed AFib, their blood pressure's fabulous, so they can't have the nice, easy drugs. They have to take the hard drugs like amiodarone because it won't drop their blood pressure. And so I tell them, I'm sorry, I have to give you a terrible drug to treat your problem because, we don't want you to have a stroke, and we want to keep your heart rate down and make you not feel like you're having a heart attack. And so these aren't uncommon drugs. These are drugs that we use every day, and people need them to sustain their quality of life. And so, so that's part of the reason we're seeing more of this disease. And then again, nutritional status. Underweight can be just as dangerous as obesity. Now, not extreme obesity, but a patient with a body mass index less than 18 has been found to be quite dangerous, and it affects the liver as well. And if your body mass index is over 30, we know that you have increased risk. But, it's important to know that it's extremes of wellness. So I promised to talk to you a little bit more about metabolic syndrome. And so the way to know if you have metabolic syndrome is to take a measurement of the largest part of your waist. For women, it's over 35 inches, and for men, over 40 inches. Men, your pants will tell you if you're at 40 inches. Women, we're not telling people that, so we have different sizes, right? And then elevated triglycerides. And this is a fasting triglyceride. If you take it after you eat, it will be higher, but 150. And if you're my patient and you have an elevated triglyceride, you have heard 500 times, if you'll reduce the amount of carbohydrates in your diet, your triglycerides will go down. I mean, many of you here have heard this because this is a common problem. But it can lead to fatty liver disease. High triglycerides can lead to pancreatitis. High triglycerides can lead to coronary artery disease. And what you're going to see, many of these diseases overlap in the problems that we have. And also, blood sugars over 100, even pre-diabetes, increases your risk, and that's part of metabolic syndrome. And so if you're already a diabetic, you qualify for that as well. But this is the cascade of events. Now, your HDL. Now, this is an East Tennessee problem. I'm just going to be real with you. Genetically, a lot of people around here have very low HDLs. And when your good cholesterol, your HDL is very low, you have an increased risk of heart disease. And it's part of the structure of metabolic syndrome. If you look at a map of the United States, we are in the stroke belt. We are in the coronary artery disease belt. We are in the belt for diabetes. And our HDL does play a role. And so if your family history is strong for heart disease, you need to know what your HDL is. Unfortunately, the only way to really boost this is with vigorous exercise. Not a little bit, vigorous exercise. And so if you are genetically in the 20s, I hope we can get you up 10 points, but it's really hard to double. It's just a very hard thing. I want you to try, but it is hard. Now, what about the United States? And so we estimate that 25 to 35% of our population has fatty liver or steatosis. Over 98 million people. Okay, so that's scary. And when you look and you say, as our population ages, as our population grows, if we don't do something about the pandemic of not just the coronavirus, which matters and we'll talk about at the end with this disease, but you have to think about the pandemic of obesity. And I'll tell you what I've been doing during the COVID virus. I've been eating. I've been cooking stuff my grandmother did. And, those are things that these habits and boredom have led back into. And this, is another thing for me, too, that I struggle with. But 98 million people probably have fatty liver. That's huge. It is the number one cause of liver failure among teenagers. And 8% of those teenagers that have it are lean. Now, that's scary. Yes, 92% are obese, and we are seeing childhood obesity on the rise. We're seeing this as a problem, but 8% are lean. So it is not just liver fat from obesity, but it can be what we eat too, not just what our weight is. And so if your child, your grandchild is obese at age 8, you need to be concerned, as this could be a risk factor for them. But there's no screening test. And so when we look as doctors for screening tests, we want to say a good screening test identifies the people and it can make a difference and it's cheap. And so we don't just massively screen populations because not everyone will get sick from this, and knowledge will not necessarily change outcomes. And so the way to find out if you have this is actually through blood work when you're being checked for other things. So again, thinking back to gross anatomy lab and my patients, when you look and you take a biopsy of the liver, all the red part is what you're supposed to see, but you see the big white chunks in it, that's fat lobules. And so any of you that have poured off grease and you've let it sit there a while and you see that fat that rises to the top, that's inside your liver if you have this. And so that's what the pathologist sees. And again, do you want a liver that looks like an alcoholic's liver? Not really, okay? And so again, a lot of times I find this just by doing routine blood work. And I'll see one of the 3 or 4 markers pop up. A lot of times it's a high alkaline phosphatase, and then I'll ask you to come back and I'll get something called a GGT, and that's another liver enzyme, or I'll do a vitamin D level, and I'll try to figure out, is this your bone or is this your liver? And if it's your liver, I'll do an ultrasound. Now, if I'm seeing 2 or more liver enzymes bumping up, then I'm already saying, well, it's your liver, it has nothing to do with your bones. I am concerned, and I'm going to start working you up for other things that can cause liver disease. And so autoimmune diseases can cause this. People can get autoimmune hepatitis. That just means your body doesn't recognize your liver and it attacks it. And you can have, again, alcoholism, and we try to ask you those questions. You can have viral hepatitis. And so do you remember not too long ago, McAllister's in Kingsport had an outbreak of hepatitis A. And if you remember a few years ago, Ruby Tuesdays had a hepatitis A outbreak on the spinach. And so we're at risk. Anybody that eats out, right now should be the cleanest time in the world to eat because everybody's at least washing their hands. And iron overload will make a difference. Copper overload will make a difference. And this is a lot of times genetic problems. This is not something that you've taken in orally usually. So we do a liver ultrasound. It's easy to do. We see fatty liver and we do this workup. And if everything else is negative and you're not an alcoholic, we say you have non-alcoholic fatty liver disease. And then what? And then you'll get a message from me. It's time for dietary changes. What would you like to do? Would you like to meet with a nutritionist? Would you like me to teach you? Would you, we'll check this again with an elastogram in 6 months. And so used to, all we had was a liver biopsy. So we'd go in and we would biopsy your liver. And if you've ever had a liver biopsy, it's not very fun. It actually hurts quite a bit. So now we don't biopsy everyone. We can look with an elastogram, and it's a different type of ultrasound that shoots the sound waves, and it looks for the fat and the fibrosis, and it gives us a score. Well, once we have a score, F1, F2, F3, F4, we can compare that after you've done your diet 6 months later, and we can see if you're making a difference. And I'm using that more and more. But there are people that need to have biopsies. Your diabetics, those over 45 years of age, or if you're really not sure what they have. Okay, so let's say that I have called you and I've told you that you have this and you're worried. And you say, what's my chances? 30% of people will get better. 30% of people will stay the same. And unfortunately, 30% of people will get worse. And that's if you do nothing. Okay? And so it will wax and wane over time. The liver's a strong organ. It will do its best to recover. But we start looking, what are your other risk factors? Do you need an oral glucose tolerance test? That's one way to check for diabetes. Are you at risk for diabetes? If so, if you're diabetic, you have greater risk of poor prognosis. It increases your risk of heart disease by 10%. The number one cause of death in the United States is coronary artery disease. And so you don't want to have the thing that helps you along with that. Non-alcoholic fat or liver disease is actually the 13th cause of death in the United States. It didn't make the top 10, but it contributes to number one. And so you want to start looking and say, well, what are my risk factors? How serious do I need to take this? Well, 60% of that group needs to take it pretty seriously, and you don't know that you're in the 30% that get better. And so 10 years down the road, 30% going to have fibrosis. And fibrosis is like a scar. It doesn't improve. Okay, so again, you come to my office. I've told you what to do with your diet. I've told you how we're going to follow it. And then I say, now we need to protect you from other liver diseases. And so we want to vaccinate you against hepatitis A. That's 2 shots, 1 now and 1 in 6 months. Hepatitis B, if you're in healthcare, you've had this one, but we give you 3 shots, 1 now, 1 in a month, and 1 in 6 months. This is the same shot they give babies right after they're born, and it helps you build immunity. Now, hepatitis B is from blood or bodily fluids, but you don't know who you're going to have to clean up after in the future. You don't know. Even if you're not in healthcare, you need to consider this. If you have non-alcoholic fatty liver disease, I do recommend that you have it. And then we start looking at your score. We say, okay, we did the Elastrogram, we know your markers, how bad is it? And then we follow it out every 6 months. Again, you don't want a biopsy unless you have signs of cirrhosis. If you're over 45 years of age with diabetes, if you have an enlarged spleen, if you have signs of iron overload, or what we call cytopenias. Cytopenias means a low white blood cell, anemia, or low platelets. And that's because the liver makes clotting factors, the liver makes blood products. Before you're born, the liver makes a lot of your blood products, and it kind of slows down as you age. But you can't clot if you have liver disease. That's why people with liver disease, a lot of times you'll see spots on them from where they bled under their skin. And so it's important that we check for that. Even though iron overload is on here, more and more we're doing fancy MRIs. We're trying to save people from biopsy. So it's not a slam dunk, but these are the things that we think about. So the stages over time to cirrhosis. First, you have a nice fatty liver, like I talked to you about my cadaver, and over time it starts turning a little bit more yellow. You get those fat lobules in it. Remember, that's not just externally like I saw in the anatomy lab, it's internally, and it's inside the organ. And then it just continues to progress, and there starts to get fibrosis, and over time you have cirrhosis. And what we're screening for with the protein alpha-fetoprotein is for liver cancer. And that's largely, the patients who have hepatitis C have greater risk, but that's what we're looking for, and that's the stages. Not most people with non-alcoholic fatty liver disease that die from liver disease die from cirrhosis, not liver cancer, but that's important just to note that those are the stages that we're looking for. And so it's important that we treat this early on so that it can back up and not progress. Yes? No. Once you start getting fibrosis, it's harder to reverse. If you still have some good tissue, it can improve, grow, and reverse. It depends on how bad the cirrhosis is. But no, now, if you have cancer from another organ, okay, so if your colon cancer goes to your liver in one lobe only, they can cut out that lobe, take it out, and your liver can regenerate. It's not because of fatty liver. So it's just, I was trying to teach how amazing the liver is. Like, it's an amazing organ. And so it can heal far more than you can ever imagine. You can't give up on this disease if you have it, because you can get a lot better. You have to try. So, yes? Absolutely. But that's most of the lecture, so I have to build you up and not let you down. Okay, so how bad is bad? If your non-alcoholic fatty liver disease that was just found in blood work goes on and it becomes fibrosis, you have non-alcoholic steatohepatitis that moves on to cirrhosis. With cirrhosis, it increases the blood pressures in your stomach at the liver, which causes more pressure and more backflow at the heart, the aorta, and up into near the esophagus. Okay, and because of that, there's increased pressure, so it can't push past it, so it kind of balloons out. And so people will get esophageal varices, or little bleeds in their esophagus. And that's very dangerous because their blood's also getting thinner because the liver's not functioning properly. It's not making as many clotting factors. And so if they get a GI bug or something and they are heaving or coughing, they can actually pop one of these varices and cause a massive GI bleed. And, I don't want to gross anybody out, but that is not the most enjoyable thing to take care of as a doctor. It's very hard to see, and it's very hard for the patient. You also get what we call caput medusa, where your abdomen swells up and you externally get blood vessels that you can see, and you can see the blood vessels marching through the stomach. It increases the hemorrhoids. Anything that's a blood vessel just kind of pops out because it's having to push past a pressure. Ascites can happen, and that's when the liver failure is so bad that your stomach swells, you start turning yellow from the jaundice, and we have to go in with a needle and we have to draw fluid off your stomach just so you can breathe. And again, this is not everybody, but some people will progress to this, and this is why it matters. And then there's a condition called encephalopathy, and you all are reading about that with the coronavirus, that it can cause that. But with liver disease, it goes on for quite some time, and it can be to the point where you just don't know the ones you love. I have one patient right now, she believes someone's trying to kill her all the time, and someone's beating on her door, and her kids live with her, and they're like, you're fine, you're okay. But she believes and she hears those voices because of her liver failure. And it's this very scary disease. And, you know, I had a lady tell me before she did the diet I'm about to teach you, she said, I worked at the hospital, and everybody would say, you don't understand, this isn't her, this is not her, we've got to push, we've got to save her, because she was so confused. And then we give you medicines to try to bind up the waste products called ammonia, and it gives you diarrhea every day of your life, but that's to keep the encephalopathy down, so it is not a good thing. We talked about the cardiovascular disease, that it increases your risk, and, you know, if you're not doing the diet, and if it's not reversing, and if you have those horrible side effects I just told you about, which again is not everybody, but if you're unlucky, then only if you're healthy will you get a transplant, because we don't have enough organ donors in our country. And so 30 to 40% of NASH-related cirrhosis need transplant. And so you don't want to be that person. And so now we've got to talk about how to regress it, because you all don't want it, right? No one here says, sign me up for some liver disease. You know, it's scary. But this is how amazing our liver is. With just 10% of weight loss, you can have near total regression of disease. So if you're 200 pounds, that's 20 pounds, okay? So it's not you have to go down to your ideal body weight. You know, just a little bit goes a long way. 5% changes our labs and makes it look better. And so that was 10 pounds for that example I gave. So it's doable. But again, children who are lean can still have fatty liver disease. So it's sometimes just what we eat. Now, you notice I put an X over, you can't regress cancer of the liver that's throughout the liver. That's why I put an X over that. And I was just trying to show you that the arrows went the other direction. But weight loss matters, but what you eat matters. And so the studies have been done in the Mediterranean diet. And so that's what I'm going to talk to you. But the vegan diet very much applies. I just couldn't find the studies to show you in that area. So I'm going to show you the studies that we have. But I want to talk about medicines and show you that we fall short. Medicines aren't the answer for this. We throw well call at people if you have massive diarrhea, but there's no evidence that it helps this, even though we thought it might. Actose, pioglitazone, is a diabetic medicine that does tend to back it up a little bit, but it didn't save anybody's life. And statins, now I know you all hate statins. Everybody tells me how bad you hate your statin, and I spend half my career telling people why I love statins. But these cholesterol-lowering medications can bump up your liver enzyme, but in long-term studies of cirrhosis actually show improvement. It's not going to completely save your life just giving you a statin from this, but it does help lower your liver enzymes. But if you see a 3 times increase, you can't take it. So we have to look at it carefully. Again, if you're diabetic, we can't give metformin if you have very advanced liver disease, but it actually tends to help it if you have the starter of disease. And we talked about vaccinations, and I threw 2 more in on you just because I like vaccines. And if you have chronic diseases, we want to give you the pneumonia vaccines as well, just to help prevent you from preventable diseases. And remember, any autoimmune disease that you have, or any chronic disease that you have, it lowers your immune system just a little bit. And then there's antioxidants. What about vitamin E? So before my training at Wake, they used to give everybody vitamin E. They said, oh, you got heart disease? It's an antioxidant. It has free radicals. We'll give you lots of vitamin E. It actually caused harm in cardiovascular disease, which is odd because it's water soluble. It should be excreted. But in liver disease, they've seen some studies that showed benefit and some that didn't. So we're afraid to give it to diabetics. We're afraid to give it to people with coronary artery disease, but we will give it to the people who don't have those conditions. And then there's a blood thinner that we can also use as well. But again, there's no harm or benefit, so why would we treat it? So we do try to optimize diabetic control. We try to optimize your coronary artery disease risk, but largely we try to change your diet. And so that's really what I want to teach you today is how can you look at things a little differently. And this is where I want to tell you about some podcasts that I've been watching. Craig Groeschel with Life Church, he's been doing some leadership podcasts. And he said in his 30s, he started changing one thing a year. He said just one thing, one attainable goal every year. And he said, one year I decided I would only eat dessert once a week. He said, I stuck with that. And he said, now over the last 20 years, I'm down to maybe one a month. He said, the next year I decided I needed to exercise, so I chose 3 days a week, and I exercised 30 minutes a day. And he did that, and over time, there was change. And now he exercises an hour and a half a day. I'm like, how do you have time to work? But anyway, small changes now create big changes later. And so even if you just take a morsel of this away with you, and you make a change, remember, 10% of your body weight coming down will make a huge difference in liver disease. We want you to be healthy. We want you to gain success. But sometimes if you go in guns a-blazing, you're setting yourself up for disaster. So sometimes you got to make small, steady changes over time. Just depends on your personality. I'm a go big or go home kind of person. You can ask my mom. But I think small, steady changes probably last a lot longer. And so you want to look at eliminating fructose from your diet. You want to kick out the soft drinks, the fast foods, the quick go-to things, and you want to increase your omega-3 fatty acids in your diet. And I do like to say diet because I do caution you, high levels of omega-3s can thin your blood, and if you already have liver disease, it does matter. Okay, yes? Groeschel, Groschel, and just type in leadership on Podcaster, and it will bring it up, and it was December of 2006, and that's the one that talked about lifelong changes and how to make them. It's excellent. So if you look at this, and the last time I spoke, this program was called CHIPS, and so it's been a few years ago, and it was just talking about the many colors of food, and I assume that that's still a major focus of this class. And so this picture kind of brought that up to me and said, you know, it does matter what we put in our mouth, and it does matter the variety that we give, and to make sure that we're getting all our nutrients. And so remember that not all fatty liver disease is from obesity, and it doesn't matter what we eat. And I'm going to pause here just to talk about an NIH study. And so the National Institute of Health decided to take a bunch of 16-year-olds out to McDonald's. And they all went to McDonald's and they said, get whatever you want. We're going to pay for it, but first let's do an ultrasound of your brachial artery right through here. And it was just pumping like a 16-year-old should. It looked good. And they said, order whatever you want. And so they went and they ordered, I don't know, Big Macs or cheeseburgers or chicken nuggets, and they ate, and then they did an ultrasound of their arm. And that blood vessel stopped moving, and it just sat there. And it stayed there for 48 hours, okay? So what's that do to me and you, who are a little older than 16, over time? I mean, it makes a difference. And so it matters what you do. In World War II, whenever we did autopsies of our soldiers, they found that even at age 20, we were starting to get plaque, atherosclerosis. And so if you look and you step back and say, that was before fast food. You know, we Americans have consumed such terrible things over the last few years out of convenience that it's caused major problems. So what the Mediterranean diet is basically you look at the food pyramid and you want to do daily physical exercise. One lecturer I listened to said you need to think of it like religion. You need to read your Bible every day and you need to exercise every day. And then the whole grain foods would be the next category. And then all the fruits and vegetables you can eat. You can have nuts, you can have beans, you can have any vegetable you want. And then your oil source needs to change. Instead of butter and margarine, you need to use olive oil. And then going from up to there, they then list out the seafood, the chicken and fish, and beef, pork, and sweets need to be so rare. You know, they recommend on this pyramid, if you have it at all, it should be once a month. And that's really hard to change. But just like Greg Groeschel said, he made one small change, and over time it became big changes. And so, you know, my name happens to be Candy, and I struggle with that, okay? I really like sweets, and I've got to get it into my head that that is not good for me, and it doesn't need to be a daily thing, but a more rare thing. And we talked about exercise a little bit. I always say you start low, 3 or 4 days a week, build yourself up, work toward 45 minutes a day. and try to get your maximum heart rate up, and that's 220 minus your age. Diabetics, if you will exercise just 15 minutes after you eat, you'll drop your blood sugar more than 45 minutes straight at a time. And so that's just another way to achieve glycemic control. Now, if we have a patient who has said, okay, I have been faithful with my Mediterranean diet, or I've been faithful with my vegan diet, I've been faithful, and, I'm making progress. That's what we do. We just keep doing that Elastrogram. We keep checking your labs, and things should regress. But if you've struggled and you've not done well, and you say, hey, it's not working, or I'm fearful after 6 months, they actually do recommend that you can have bariatric surgery for this condition. But you have to do it early on, because you want to see change early, or you'll go on to fibrosis, and that's when you see the biggest change. So again, 6 months is about what we give you, and it depends on your motivation and what you do. And so in Greenville, you can have the sleeve surgery, but gastric bypass has to be done in a larger city. So how do you further educate yourself? So this is what I recommend. Sit down with your primary care doctor. Say, what are my liver enzymes? If they're elevated, dig in a little deeper. What is the GGT? Is it just vitamin D deficiency that's causing your alkaline phosphatase, or your bone, or is it your liver? If it's your liver, be sure you have not accidentally had exposure to viral hepatitis. I had a patient, she came in and she couldn't feel her tongue. She couldn't feel her tongue, couldn't feel her tongue. I did every workup in the world. It ended up being hepatitis C. She worked in the pre-glove era in a dental office, and she got it in a cut in her hand. And so those are things that you have to work up. Don't assume just because you've not done drugs and you've not been wild that you don't have it. Just check. And start making the lifestyle changes. Follow your Elastogram. See where it leads you, and do the necessary changes. And if you're a gung-ho, get-it-done person, great, more power to you. But if you need to make those small, gradual changes, do, because it can definitely change your life. Now let's talk about the coronavirus just for a second. So, as you know, what we tell you about the coronavirus changes day by day, and many of you feel very frustrated at that. But we don't know much about this virus. It's new, and new things are coming out, and it depends on the weight of the studies. But non-alcoholic fatty liver disease has been shown, if you have moderate to high fibrosis scores, to lead to a more severe disease. So my take home from this is, we're doing social distancing, we're wearing masks, we're trying to do things to protect ourselves from passing this on to those who are the highest risk. Why don't we use this time where we're home more to increase our exercise, to learn to cook these new recipes, to actually make positive changes instead of what many of us have done at first, just stress eating. And so this would be a good time to say, okay, we've got another year and a half, most likely, before we have a vaccine. And so let's make the most of this next year and a half and do it for healthy eating and healthy lifestyle changes. We don't have to do like the rest of the world and be crazy. We can have East Tennessee to glow in this one aspect. And so I'm open to questions at this point. Well, I'm really glad you asked about the gallbladder, because I forgot to say this point. I had a 40-year-old who came to me to get her well, I didn't take her gallbladder out, but she came to me after her gallbladder was out. And Dr. Bulawa had said she had the most cirrhotic liver she had ever seen in her life. 40 years old. She was pre-diabetic at the time, and she was already in cirrhosis. And it didn't show up. Her liver enzymes didn't bump for 10 years. So it doesn't matter that your gallbladder is out. It won't affect this. The appendix won't affect this. But that's what the surgeons are seeing more and more now. They are going in, taking out these diseased gallbladders and going, oh, no, look at these livers. If you're going in, read the fine print. See, they are putting on their forms, can we biopsy your liver if it looks bad? This is way more prevalent, 98 million people. Than we know. And so no, not having a gallbladder, not having an appendix doesn't matter, but that's how we're diagnosing some people.
I was just going to say, if people have a question so everyone can hear, can you come and use the mic or at least speak loudly?
Okay. So you don't have the tail end of your pancreas or spleen. So not having a spleen is a major problem, not because of this, but because you can't fight off things like anyone else. And so you need to really talk to your doctor about vaccinations to protect you from what we call encapsulated organisms. Not having your pancreas increases your risk of diabetes. You still have some, you're diabetic, so that increases that risk. And so it might change your blood flow a little bit, but it doesn't increase your risk that we know of getting non-alcoholic fatty liver disease.
I can speak pretty loud, but I'll use this anyway. I am working with Dr. Eric Bulua, okay, on a diet to take my weight down and everything. And one of the things he has said is avoid starchy vegetables. So I'm not allowed to like eat carrots or lima beans or, you know, the usual stuff. Now, is that because, I mean, is that valid for the diet that you're talking about, or? So
I worked in the same office with Eric, and he would judge my food on a daily basis. And so Eric's studies are in lowering carbohydrates because you will get fast results. When you reduce your carbohydrates, you feel full and your weight will come down. But there was a study that went head-to-head, low carb versus Mediterranean, and there was at the same weight loss, there was a 50% reduction in liver fat from Mediterranean that did not happen with low carb. However, he's still right. You'll still lose weight, but you have to do both together. And so my poor husband, I put him on both when he's dieting. I say, you have to do low carb because that works for you. And his mother's diabetic, and I want his weight to come down. And he's starting to get earlobe creases, and his hair is thinning from front to back, which is a sign of cardiovascular disease. And so I put him on Mediterranean for that. So that he has to do both diets. And it is restricting, but you'll be more successful if you combine the two, in my opinion. Okay, but you can't just do low carb and reduce your liver fat. Yeah, there's some signs, like if you have a crease in your earlobe, or men are losing their hair from front to back, it's a sign of cardiovascular disease. It's not that we're going to go stress test you because you're losing your hair in that direction. It's just maybe you should start eating right. It's kind of like family history. We need to do something about this. We need to be careful. Dan's granddad died at age 60-something because of cardiovascular disease, but he smoked. So my job is to nag and harass him until he eats healthy. And I'm just using those techniques to scare him. And when I'm doing a physical, I'll say to people, do you know you have an earlobe crease? And they'll be like, so. But those are just little things that we see. It's not, it's just signs. It's not like an abnormal stress test. All right. Any other questions?
So if I ask my doctor to test me for my liver enzymes, is that across the board? Everybody agrees on what those are? Or do I need to ask for specific?
A CMP, they will. That's the one they'll get, is a CMP, and it's your start. I kind of think of it as a tree. It's the trunk, and then it leads you down different paths. And even that, you can't just be screened. You'll have to have a reason. They can do it based on screening for diabetes. Insurances require a code to get it. So when you ask for it, you can say, I am concerned because I went to a lecture and I want to know if I have it, but it's my annual screening for diabetes anyway, so I came fasting for you. But please add those liver enzymes in. That's how you can get it coded. We have to play tricks on that, don't we, sometimes? Right here.
I have a 23-year-old son who is severely handicapped, and he's fed tube feeding. And just in March, they've started doing studies, and they tell me that he's already got severe fibrosis and cirrhosis. I have a couple of questions. Number one, is this something that's been brewing for quite a while and nobody's ever caught it because they haven't tested, even though he's been losing his hair and all the signs you're talking about? And at this point, what is a prognosis? And since he's on tube feedings, what can we do about the tube feeding? I mean, we can't follow the diets.
Correct. There are studies that show that tube feeds and or TPN, which is feeds through the IV, can actually cause fatty liver disease. So while they're the cause, they're also the only thing that he can eat. And so any disease that you get, you have to weigh the risks and the benefits. So I would ask for a nutrition consult and say, now in light of this finding, what can you do in tube feeds that gives us the best that we can? And that's the thing about medicine. We get between rocks and hard places all the time, and you have to do the best that you can do. And, you know, you want to keep him at a good weight. You want to do even chair exercises, but you can't not feed him, right? And so you meet with the nutritionist, you do the best you can, and this is one of those things you say, Lord, give me wisdom and help me, because, you know, maybe the doctor will say in this situation, if he's not diabetic, maybe vitamin E would be the thing, maybe a little bit of metformin depending on his liver enzymes. Maybe in this situation you would do a little Actose, and you could do the Elastrogram to follow it. But you're not, medicine is an art. There's the science of medicine, there's the art of medicine. And the art part takes that individual patient and says, okay, in this situation, I have to look at it differently through different glasses, and I have to do the best that I can with what I can do, because you can't, you know, you have to feed him, you know, and you know, you can ask the nutritionist, you know, may I do juicing? May I, and work with them and make sure it's someone that understands fatty liver disease that can help you. But I'm sure that there's a nutritionist out there that will take interest.
Is a plant-based diet, along with taking some omega-3s, like in the flaxseed, better than the Mediterranean diet with regards to this disease?
They did. I looked everywhere to try to find that answer, and it's just not been studied that way. And so in my mind, it should be. It should be, and because it decreases inflammation. But I always have to look at who my population is too. And if you are going to do it and you will stick with it, I think that's probably the very best, healthiest diet that you can do. But I do work in East Tennessee, and I work with a lot of people who grew up on farms, and they had big plates of, you know, gravy and biscuits, and, you know, so if you will do it, yes. And if not, I go back to Greg Rochelle, and if I can talk you into a little change over time and make changes, but the vast majority of studies are in the Mediterranean diet. And so, again, you merge those diets. Like I merge my husband's diet, low carb and Mediterranean, but he won't go vegan. I made it in our house for 3 weeks. I mean, it's just not going to happen at my house. But at your house, maybe you can make it happen. And you say, okay, we're going to do that, and I'm going to measure my fat over time. And, you know, if you have a hiccup in your lab, stay the course, see what it does over the next 6 months, and reevaluate. And then you might have to say, okay, well, let's look at those studies again and see where we are. It's a really good website that I think everybody should know about. It's called clinicaltrials.gov. And if you have a disease and you want to be a part of a study, you can actually go online, put your disease in there, and I do this for a lot of my cancer patients, and say, hey, where are these studies in the world? And it will be the whole world. I would range it down to English studies and probably in the United States. But, you know, you can call these people and say, hey, do I qualify? And you can actually take a part in these research trials if that interests you.
And is there a difference between the olive oil, avocado oil, and the grapeseed oil? Do they all have the same benefits?
The studies are in olive oil. I assume they're pretty well similar. But, Arvo, do you have a thought on that?
No, it's just better to eat the food rather than use the oil, but when you use oil, olive is probably the best.
Thank you. Anything else? Yes. So I am so excited. They're like miracle drugs. Now, that being said, they're $80,000 too, okay? And so it is amazing that in our lifetime, we can see a cure of hepatitis C. This is amazing. And it's only for a short period. And remember, the liver can regenerate. And we are seeing people have to be able to stand the drug, because when it was, you know, ribavirin and the harder preparations, people couldn't stand to take them. And now we have drugs that people can stand to take and cure disease, and we're not seeing it come back. So it's amazing to me. That gives me goosebumps. I love it. because hepatitis C can be cured. And that's why this disease will rise as number one, because Hep C will go down and down and down. We have vaccines for A and B. We don't have a treatment except for people to change their lifestyle. And how stubborn are we as people? Look at Americans are stubborn. If you're not watching the news, we are stubborn people. So we have to make a lifestyle change. And that's why you all are interested. That's why you're here. You will make a difference in your life. But how many people in America aren't going to change their lifestyle and do what they're supposed to do? Well, Hep C will go down. I love those classes. It thrills me. But I'm a nerd, remember? So, okay. Anything else? Gotcha. She asked about hepatitis C treatments. The new meds on the market, there's several of them, and hepatitis C can be cured. And she was asking me about my thoughts, and it's exciting. Yeah. Okay. Anything else? All right. Thank you very much. And I really appreciate you having me, and I look forward to being back in Greenville.
Thank you so much, Dr. Overholt. It's a pleasure to have you. And I want to just make you aware that when you leave tonight, there is a little magazine here that we would encourage you to pick up on your way out. It's called Signs of the Times, and it's a special feature on COVID-19. So please grab one and take it home and check it out. Let's bow our heads for a word of prayer. Lord, we thank you that you have brought us here safely together. We thank you that you have made our bodies in a beautiful manner so that healing can occur, and that when we follow your principles as outlined in your scripture, you give us not only hope, but you work your divine miracle in our life through the means that you designed back at creation. And I pray that you will give us all the courage and the strength we need, that when we go to our kitchen, when we sit down to the table, that you'll give us the willpower, for we are in desperate need of your strength and your Holy Spirit. So help us to this end, that we might live lives full and more abundantly to your honor and glory. We ask this in the name of Jesus. Amen. Good night. Be safe. We'll hope to see you soon.